Hello, my friends, and welcome to Take a Deep Breath. My name is Mike Maher. I'm a breathwork coach and the host of this podcast. And in this episode, this is in case you missed it. So what we're doing in this episode is I'm just going to bring you a couple of mini clips of conversations that I've had recently with some of the world's greatest experts in the world of wellness, breath, and so much more. And then I invite you, if you find something that you missed or something that you really are intrigued about, then the links are down below to go and watch the full episodes. So let me know how you get on with this. Got some great guests coming as well, so make sure you click the subscribe and follow buttons. And for now, let's get stuck on with this episode. Thank you. The following is a clip from a conversation I had with James Nestor. James is a New York Times best-selling author of the book Breath, The New Science of a Lost Art. And in these clips, we went really deep into the science of breathing that I don't think anybody had asked him before. So some really interesting insights here. And I highly encourage you to click the links below and watch the full conversation. Vital, I think you called it, is it the Framingham study I heard you mention on Stephen Bartlett's podcast? And is that vital capacity? So could you just explain the Framingham study and what our lung capacity's got to do with our longevity?
This was a 70-year-long longitudinal study looking at about 5,200 different people in Massachusetts. And what they found was the clearest marker of lifespan was lung size and lung function. So the sooner your lungs shrink up, the more disease they get, the sooner you're going to die. And the good thing is about lung function and lung size is we can influence this at any age. We can do this by breathing properly and by doing stretches, right? What is yoga? But a technology, an exercise of stretching and breathing to inhibit that downward spiral of lung deterioration, which happens as we grow older. After the age of around 30, our lungs start getting smaller and smaller and smaller. We can reverse that with proper breathing techniques.
Now, is it that the actual sacs themselves that are getting smaller and or tighter rib cage, weaker diaphragm, or is it all of the above?
It's all of those things. So from what I know, it's not like the alveoli are getting smaller or getting less. It's not at that scale. I could be wrong about that, or the bronchioles are getting less. But it has a lot to do with the bones. The bones become brittle. They become less flexible. Right. And and when that happens, when we start losing bone mass, our posture gets crappy, we start shrinking, which is what happens when we get older. And we lose the ability to truly inflate our lungs properly when we take a deep breath. But just like anything else, this is easily reversible, not only by adopting proper breathing habits, but just by exercising, right? Mild to moderate exercise helps to stem off that deterioration in our lungs. And I think you need to add nasal breathing to that as well, so you don't constantly expose your lungs to everything in the outside environment.
Yeah. Just wanted to link back to the Coherence one last time. Any ideas why heart rate variability would increase with Coherence breathing? And would that be different to box breathing, do you know?
Yeah, we know why it increases, because when you are breathing coherently, your heart rate is syncing up with your respiratory rate, which sends your brain signals that it is calm. And so your brain starts locking in at a consistent signal as well. That's what I was talking about, those different waves, that coherence that happens in your brain, right? That synchronous firing of these neurons by rhythmically breathing in this certain way. So I think it's very scientifically, it's very clear. They know why why our bodies adopt these different patterns and why this is so beneficial. And this isn't controversial at all. And someone can get a heart rate variability monitor and look at what is happening to your heart rate variability when you breathe at this coherent rate. And you can see it right up on your screen. So no one's making this up.
You mentioned sleep apnea. I've done a little bit of a deep dive into this, and I've been looking for a few clients around breathing exercises they can do, because not always, but they tend to have a decent CO2 tolerance because they're holding their breath. And I've heard a couple of things, or read a couple of things around different breathing exercises where you'll pronounce a vowel or make a K sound and swallow. Have you come across any studies, evidence, or spoke to anybody about breathing exercises people with sleep apnea, particularly where their throats are kind of collapsing?
Yeah. So there's two specific areas to look at. It is the rhythm in which you are breathing, and this is something Patrick McEwen told me about years ago, and he has since published a study on this. So if you are accustomed in the daytime to constantly breathing too much, you tend to carry that breathing pattern into your sleep. So you tend to breathe too much in sleep. What he has found, this is still a little controversial, but what he has found by training hundreds and hundreds of people with sleep apnea to breathe more slowly, to breathe less, as they tend to carry this respiratory rate, these breathing habits into their sleep, and thus have significantly less sleep apnea. He showed me this trick. He's like, try to breathe heavy through your mouth and make a snoring sound, right? Really easy to do. Now try to breathe very slowly in and out through your nose at a very easy rhythm and try to make that snoring sound. It's impossible to do. So he thinks that the flow of air coming into the airway can really affect our incidence of snoring and sleep apnea. So that's the one side. It's the flow. The other side is the structural, right? It's the pipe. And so many of us work out different areas of our bodies, but we don't work out our airways. So by doing these myofunctional exercises, they're called oral myofunctional exercises, oral pharyngeal exercises, all terrible names. All they are is exercises for your tongue and your mouth. And this allows for those soft tissues that are becoming flabby to firm up, just like any other part of your body would be firming up if you're working it out. And there's been several studies showing that this can be significantly effective for people with both snoring and sleep apnea. There aren't enough studies, I don't think, but there are several. I think I found about 6 or 7 that showing just doing these mouth exercises. So if you combine those mouth exercises with the slower and less breathing, what's it going to harm? Nothing. You're going to be a better breather. You have a more toned mouth. Will it fix all of your sleep apnea and snoring? I have no idea, because everyone's different. But it can only help, right? For some people, it could help tremendously. For others, maybe just a little bit. But for me, it's worth the bother.
Yeah, for sure. No, I love that. Since we've last caught up, which was in Costa Rica a couple of years ago, and I don't know where, well, a year and a half ago, I don't know where time's going, I've become obsessed with coherence breathing. It's become like my favorite thing now to do. It's a daily practice, do it with all the people that I work with. And so I'd just love to get your thoughts a little bit more on this in terms of not necessarily the going down slow and the CO2 benefits that you're getting, but more what else is going on? Because I've heard things about the heart syncs up with the brain. You can see EKG, ECG, I think, or it might be the right terms, but I've got those wrong. There's stuff around blood flow. There's the chap, I forget his name now, the scientist that came up with the term. He says around a wine bottle's worth of blood flow goes to the brain with each exhale, and that's doing something with some waves. So I wonder if you could just demystify a little bit of this coherence breathing, about what else is going on with it, why it's so lovely.
Yeah, so this is definitely one of my favorite, if not my favorite, breathing technique. And the reason is it's so simple. Anyone can do it anywhere. You can practice this all the time. There's no such thing, from what I've seen, of doing this too much. There are problems with not doing it enough, because you're not able to breathe coherently. So what coherent breathing is it's just inhaling and exhaling at a rate from anywhere to 4 breaths to around 7 to 8 breaths per minute. And the reason why there is a range there, because depending on your age, kids breathe more than adults, right? And some people are more comfortable breathing less air than other people. So you have to find that breathing pattern, which for most people is right in the middle of that 4 to 8, right? It's right at around 5 to 6 breaths per minute, which is about 5 to 6 seconds in, and 5 to 6 seconds out. So again, this is for most people, not for everyone. And when you do this, and you can see this if you're looking at your heart rate variability in a real-time readout, you watch what happens to your heart rate, which lowers, your blood pressure will normalize. By normalize, I mean that people with low blood pressure will see their blood pressure rise up to a normal level, and people with high blood pressure often see their blood pressure decrease. And they've also looked at the brain, what happens to the brain. And there's this synchronicity of different areas in the brain, the synchronizing. And these different brain waves tend to go into the alpha stage, these stages that are considered to be more associated with levels of deep meditation or focus. So there is a whole bunch of different things that happen to your body, not just with your blood oxygen levels, but all across your body when you're breathing at a rate that is at peak efficiency. And that's what resonance or coherence really means, that something is operating at peak efficiency.
I heard from our mutual friend, Tom Granger, who wrote Draw Breath, saying that there's a theory that maybe humans used to breathe at this rate many eons ago, and we've just been speeding up ever since. Have you come across anything anywhere in the literature about that?
If only we could go back in time and test that. But we can't. What we can do is read ancient scripts, which is what I spent a few years doing. And it looked like our ancients used to breathe significantly less than we did. The Bon Buddhists believe that breathing at a rate of around 7 breaths per minute was the key to proper breathing. And if you look at the ancient Chinese, they were breathing at a rate of about 8 breaths per minute, 9 breaths per minute, which is great. If you consider what is normal today, 12 to 18 breaths per minute, I think that's way too much. And just 50 years ago, what was considered normal was 8 to 12. So you see what's happening. Maybe next year it's going to be 18 to 30 breaths per minute because we become a population of hyperventilators. You don't need to breathe that often. It's so inefficient for most people.
Yeah. I was talking to a doctor the other day. He was a leukemia specialist, just happened to be at a party I was at. I was fascinated. He was talking about the levels of leukemia country versus country and how they were different. Like Japan's really low and West is really high. Have you seen anything around respiratory rates country to country? Have you ever gone into that level of detail?
I spent a few months working with a research assistant trying to find this, and there's just no good data. You can look back in history, which is what I did. I think I found a dozen studies showing that people in the 30s and 40s and 50s were breathing significantly less than we were, according to these studies. You know, I guess the best thing that you could do is look at the few populations that have not been industrialized, right? The HASDA, you could look at them and look at how they're breathing, and they don't have high blood pressure, they don't have heart disease. And from what I've seen, they breathe significantly less than we do. They're not hyperventilators, they're not mouth breathers. So just look to nature, right? Look at other animals that haven't been completely destroyed by industrialization. Look at how they're breathing through the nose, in and out, softly, rhythmically. That's how we should be breathing as well.
You know, I've seen this around a little bit on the internet. Breathe less, live longer. And we know all the benefits, but do you think there is something so basic in slowing our breath rate down might actually be a longevity market in itself by slowing the heart rate down?
Well, that's what BKS Iyengar said. He's like, a yogi's life is not measured by his days, but by his breaths. So I think everything that we know, that all this cascade of benefits we get from breathing slower, breathing less, breathing deeply, all of the stress that releases, all of the oxygen we get more easily, it makes perfect sense to me that the slower, more rhythmically you breathe, the easier it is for your body to live longer. There will never be a study on this at all, but just on paper, that makes a lot of sense. It can't hurt. I'll put it that way.
Okay. Love it. Hey, just pausing the podcast for 2 seconds to let you know about Breathwork in a Blink. Now, this is our newsletter that comes out every Friday, and it's designed to be consumed in less than 5 minutes. And I'm packing this full of breathwork goodies for you. We are sharing top breathing exercises that you can practice for free straight away. The studies that I've been researching, we're sharing those with you as well, so you can read, share, and do what you want with them. And there's other goodies in there, for example, what we've been talking about inside my private breathwork community, and all other things related to the breath. So it's less than 5 minutes. It comes out once a week, and it allows you to deepen your own breathwork practice. So you can click on the link below and get started today. And when you do, you'll also get some extra freebies sent to you as well. Okay, let's get back on with the podcast. This is a clip from my conversation with Dr. Rosalba Courtney, a breathing therapist with over 30 years experience helping people unwind and fix their breathing. She has a very unique approach to the breath, and I've learned so much from her. So again, if you enjoy this clip, I highly encourage you to click the links below and check out the full conversation. So let's just start with breathing as a pump. I heard you mention this on a couple of podcasts.
Breathing.
Could you just break that down for us?
Yes.
Yeah.
So breathing as a pump. Yeah, because one of the primary functions of breathing is to create pressure change. And that pressure change, of course, is how air comes from the atmosphere into our lungs. But the pressure changes produced by breathing pump other things as well. They will pump venous blood, back to the heart. And also part of that blood will go to the liver and then come back on the next breath and go into, back to the heart. So, and the pressure changes produced and the movement of venous blood starts to pump other things like lymphatic fluid and cerebrospinal fluid, because our fluids, the fluid systems in our body, venous blood, cerebrospinal fluid, and even lymphatic fluid, they're all, there's a fixed space and an amount of fluid, and that fluid needs to be in different forms, needs to be directed around the body. So breath is creating the movement, and it's one of the reasons why I'm not only a fan of slow, relaxed breathing, but I also like some of the strong breathing techniques because of the effect that they have on stimulating this movement of fluids throughout the body.
What are some of these stronger breathing techniques that you practice to help move the fluids?
Any number of them. Just breathing where, you can do all kinds of things. You can focus with a held inhale, but a big breath, and then an exhale. Or you can make an exhale-focused breath where you breathe out with force, like a type of breath. Or you can just make a big in and out breath. You can use movement, if you want to stimulate lymphatic fluid by creating movement, because also, movement will increase venous return to the heart and therefore begin to move the fluid systems and change the shape of the rib cage. So even using breath with movement. So yeah, the whole thing with, my approach to breathing is you think about what is it that you're trying to achieve. Because I'm a health practitioner, I'm an osteopath, and also worked in other fields, like nutrition and acupuncture, Chinese herbal medicine, and so on over my 45-year career, But it's like I'm thinking I'm used to being a practitioner and having patients in front of me who have some kind of issue or problem. So I don't primarily work in the wellness space. So people come with problem they're having, and because I know the breath does so much, I will then work with the breath, to help support whatever physiological change I'm trying to get in that person. So for example, if someone's got a migraine and they're trying to, one of the things we know about migraine, for example, is that there's often a decrease in intracranial pressure, that's contributing to that migraine. So if you want to kind of just stimulate pressure dynamics of fluid through the head, then you might use strong breathing techniques. Like, I think you've used something like this, Mike, haven't you? And it's worked for you.
Yeah, Wim Hof, yeah.
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 Using big breath in, big breath out, and using really quite, I don't know exactly how you do Wim Hof. I think there are some different styles coming out now. But what I'm familiar with, and maybe this is how you were doing it, Mike, is breathing big in, big out, right? Through the nose or through the mouth?
Yes.
Finger? What do you do?
Through the mouth generally. Yeah.
Through the mouth. Okay. So, which really giving you big volume changes, big movement changes in the rib cage. And every time you breathe in and the rib cage expands, you're getting venous blood actually going back to the heart, but also coming out of the head. And then when you're breathing out, it's moving the other way. And cerebrospinal fluid is moving the opposite to venous blood.
Better.
So that's breathing as a pump in a nutshell. Okay. But also, yeah. So also, when the diaphragm contracts, pushes down, and it pushes down and creates some real mechanical pressure through the lymphatic system. So you've got lymphatic vessels sitting right under the diaphragm that would get stimulated by the inhalation. And there's this really interesting thing that happens with venous blood where most of it goes back to the heart. Some goes to the liver before it heads off and goes back to the heart. So breathing is helping to do that as well. So you're moving lymphatic fluid, you're pumping that lymphatic fluid, particularly around that subdiaphragmatic area with strong breaths. I mean, I started off with potato and it was all about, decrease your breathing as much as you can, relax your body, decrease your breathing, control, reduce the breath. And that was very much how potato taught it as well, because the focus is just on CO2. So, and then the more I learned about breathing, the more I thought, but it's not just about CO2. The breath heals on so many different levels. It's a tool, it's a tool. It's like a Swiss Army knife. I've had lots of people say that, something I've thought myself. It's just a tool, and it's just which bit of the tool you're choosing to use, And the whole IBT approach is about making it specific for the person on the basis of their physiology. So, for example, these strong breathing techniques, like people used to do a lot of the holotropic breathwork in California, in the 70s when I was traveling there, super popular and people having amazing experiences and really feeling great and breaking out of all sorts of things. But some people couldn't take it, like it would actually tip them into quite a strong respiratory alkalosis. And in workshops, that I went to where there were lots of people, I would see lots of people going into tetany, clawing hands, and some people getting the jerks, and some people even having seizures. So, so it's a matter, and some people, when they hyperventilate for a technique, even when it's a great technique, if you actually get them to stop, they can't stop, they keep going. And it might be visible, you might be able to see it where they just can't stop doing the big breathing. Or it's silent, and you measure them with a capnometer and you find that, that strong hyperventilation breathing, it's actually triggered them to keep hyperventilating for hours later in a kind of a hidden way. Shall I keep talking about that? Because there's something.
I'm just curious. Why would that be? What would be causing them to keep hype? What would?
Yeah, they call it it's been well researched. It's called a flywheel effect, and it's like people who have a dysregulated biochemistry of breathing, meaning that their compensation systems aren't working well. Their compensation systems have been blown out, probably from years of, intermittent hyperventilation. They've kind of lost their bicarbonate buffer, and the mineral balance has gone off in them. And when they hyperventilate, most of us, when we hyperventilate and our CO2 drops right down, the brain responds by wanting you to stop breathing. So you get that lovely peaceful feeling, the hypocapnic apnea, you'll get that lovely peaceful feeling. You won't feel like breathing, and it just feels really lovely, and you can just linger there in this special stillness of hardly needing to breathe at all. And it's absolutely gorgeous. But some people, they get the opposite. They just keep breathing, and that's because of that flywheel effect. It's an abnormality of breathing control. That's kind of neurological, but probably linked to broken compensation mechanisms. So the person who wrote about that, who did research on that, was Hans Folgering. And Hans Folgering worked together with some important respiratory psychophysiologists. He was involved in developing the Nijmegen questionnaire, and he was a prominent member of, ISAP, the International Society for the Advancement of Respiratory Psychophysiology. But it's something that they'd been observing clinically. So he wanted to, check it out. So he did some research and he called it the flywheel effect. Yeah.
So I wanted to ask you about breath holds. And so my control pause was always very low, and I've always been a stressed, anxious kind of person. And that was the reason I got into breathing. And so I had a low control pause. And then I got to spend time with a free diver. His name's Tom Zitas. He's got the most world records for free diving. He held his breath for 10 minutes on a single breath of air. And he taught me his techniques. And I didn't get 10 minutes, but I did get 3 minutes. And this was in water, so there was mammalian dive reflex kicking in probably as well, and a few other bits. But a big part of what he taught me was relaxation and visualization and using the emotions. And so it made me go back and wonder how much of the breath hold is chemistry and how much of it is willpower or emotional, something else. And I'd just love to get your thoughts on some of this, because it's been bothering me for a while.
Yeah, it's all three things. That there are three types of impulses or three types of inputs into, the breaking point of breath holding. There is probably number one, most important, is feedback from respiratory muscles. So the respiratory muscles, the diaphragm and other respiratory muscles, are sending messages to the brain, saying it's time to breathe. And they'll do that kind of in line with the kind of programmed neural drive for a regular breathing pattern. And that's, for a long time they thought, it's chemicals. It's the rise of CO2 or it's hypoxia that gives the drive to breathe. But that chemical drive probably comes in as the second most important influence. And the third, of course, is psychological. And if you hold your breath, like I did some research on breath holding. I don't know if you saw my paper, but I wrote a paper that was testing the Buteyko control pause. Because Buteyko's theory was that the control pause correlated with CO2, that it could tell you what a person's resting CO2 was, and that you could tell if the person was a hyperventilator on the basis of the length of their breath holding time. And he actually patented that formula. And so I repeated, that research and got quite different results. Probably, not that Buteyko's research was wrong, but he got what he got in his cohort, working with people who were different, to the group I had. But the group that I had were just people with concerns about their breathing. They didn't necessarily have terrible dysfunctional breathing, but they had some kind of concern. They were asthma, or they just didn't think their breath was great, or subjectively they'd made some judgment about their breathing. So we measured, I measured CO2 with very good, super accurate equipment for 20 minutes and took an average. So, did it lead in for 2 minutes till the CO2 stabilized, then took continuous readings for, about half an hour while they were, distracted, like by filling out forms and things like that. And then we looked at the correlation between breath holding time and their CO2. And we found that it didn't really correlate. And in fact, there were two outliers that had very low CO2 and 60-second control pause. And it was like, oh, wow, this kind of blows it, doesn't it? This is weird. And the other thing I did was I measured their breathing pattern by evaluating, their resting breathing pattern using a protocol called the Maher, where you put your hands on a person's back and you look at the balance of the breath. How balanced is it between the upper and the lower rib cage, abdomen region? And I found there was a correlation with the Maher. There was a correlation with their resting habitual breathing pattern, with how their diaphragm was operating. But there was not a correlation with the CO2. So, that was just my data. And when you do research, it's like you get your data and then, you publish it. You make sure that you did the study properly. And your reviewers, have a sort of haul you over the coals and check everything. And did you do this? Did you do that? And that paper got published. But also, as I'm writing the paper up, I'm going and I'm having a look at, well, what have other people said about breath holding time? And it used to be like, based on the work of Campbell and so on, there was this theory, which would have been around the time that Pateko was doing his work, saying that, it's chemical drive, that creates the breaking point for breath holding. But then the more recent research is showing, actually, no, it's feedback from respiratory muscles. That is the stronger thing. And there was a really interesting bit of research that they did quite a long time ago. And you can tell it's quite a long time ago because the research would never get through ethics these days. And what they did was they took a group of medical students and they paralyzed them with curare, the Amazon hunting poison. And they paralyzed them with curare. And so these young medical students are lying around not being able to breathe by themselves. So they artificially ventilated them. Then they stopped the ventilator. And then they let their CO2 rise and their oxygen drop. And at a certain point when it was getting dangerous, they stopped. And then they asked the students, when did you feel breathless or the urge to breathe? And they said, never. So they would have, with all their muscles paralyzed, they would have died without feedback from breathing muscles. So that being said, hyperventilators do have short breath holding time. They do. And it's quite a good measure. And if you get a breath holding time like below 10 seconds, then what you know is that person has a strong ventilatory drive, coming from their brain. And people with asthma and so on, they'll have shorter breath holding time. But it's not necessarily a clear reflection of their CO2. It's a reflection of their dyspnea threshold, meaning how easily they get breathless. So it will determine how they breathe, their breathing pattern. It will determine how they use their diaphragm. And it will, to some extent, it will also determine their CO2. So I still use breath holding time, but I don't absolutely make decisions. I used to in the old days, I'd make a decision about what their CO2 probably is on the basis of their breath holding time, but now I don't anymore. I can't, because that's not what the data showed. So now, my assessments are multidimensional. So I will measure CO2 at rest and under challenge. I will, use various challenges, sit to stand, just standing, sitting, hyperventilation, provocation test and recovery. And I get quite a lot of information to decide what's happening with that person and their chemical drive to breathe. And then I assess biomechanics. So I'll check the diaphragm, the rib cage, what their breathing pattern is doing, and I check how functional the breathing pattern is. So I look at the breathing pattern in different postures, slumped, upright, and then I look to see how they respond to breathing instruction when I say, take some big deep breaths, breathe shallow, breathe into my hands, and so on. And then from that, I get lots of information about the functionality of their breathing pattern. A lot of people talk about functional breathing as if, functional breathing means that you don't breathe through your mouth and that you don't appear to be breathing using your rib cage and shoulders, and people use that term, and a lot of people go, oh, we're training people to have functional breathing because they're teaching them a particular style of breathing that's considered to be optimal. But, my model, and honestly, a lot of my PhD was thinking about, well, what is functional breathing? And what I sort of came to was like, well, functional breathing is just breathing that fulfills the functions of breathing. So then the next question is, well, what are the functions of breathing? And there are primary functions, which is regulation of oxygen, CO2, and pH. Then there's the functions of breathing. The primary function of breathing is about breathing as a pump, moving air and fluids. And then connected to those primary functions are secondary functions, which, self-regulation is a secondary function of breathing. Creation of oscillating rhythms that influence other neurological and physiological rhythms within the body. Speech and vocalization, cardiorespiratory interaction, and so on. So it's sort of like the body has to fulfill all those functions at once. So the body can't be breathing the same way all the time. You can't be breathing that way all the time because breathing has to maintain homeostasis and fulfill a whole lot of needs at the same time. So functional breathing is breathing that's flexible, adaptive, and appropriate. So it's I use that acronym EARS. I say, okay, functional breathing is breathing that's EARS. It's efficient, that's an acronym EAARS. So efficient, adaptive, appropriate, responsive to body systems, and supportive of homeostasis in multiple systems simultaneously. So it's not like, we don't want people mouth breathing. But you know what? Sometimes mouth breathing is the most functional. And sometimes there's something very lovely about using the mouth to breathe. It can feel really great to take some breaths through your mouth. And it can be a really great way to train the pharynx and the upper airway. So I just say, break the rules, but never get fixed on somebody's idea of perfect breathing. Keep your mind open and go back to the physiology, go back to the functional anatomy, go back to considering the person and their situation and their needs, and then make your decisions about what functional breathing is at that point. That being said, of course, it's better to have, nasal breathing. It does, provide so many benefits and functions. And yes, it's better, you want a diaphragm that's working. But, in some people, the most functional breathing, if they've got a flat and hypertonic diaphragm, the most functional breathing is actually to lift their chest to breathe, because their diaphragm isn't doing anything. So then it isn't what's the most functional breathing in this person. Let's just force them to breathe with their belly and their lower rib cage, because you make them more breathless, and that's been shown in a number of research studies where they've looked at people with COPD, and physios focused on just the breathing pattern, the biomechanical dimension of breathing. Start teaching them belly breathing, and they get more breathless, because they need to use the chest to breathe, because honestly their diaphragm's not doing anything. And then the step, of course, you can get them breathing with the diaphragm and the lower rib cage, but then what you need to do, you've got to first of all relax the diaphragm. You've got to get, reduce the hyperinflation, and then you'll get more diaphragm action, and you might need some manual therapy to release that diaphragm, or you might need to work with the psychology of the person, because sometimes the diaphragm's staying low, flat, and hypertonic because of some influences coming from above.
This next clip is with David Jacko Jackson, his second time on the podcast. Jacko is an ex-professional rugby player turned breathing therapist, and Jacko has a really unique view into the world of breathing because he has a strength and conditioning background, and we talk a lot about the power of the exhale. Enjoy this clip. You've got a unique perspective, I think, amongst the breath community. As somebody that's a ex-pro athlete and strength and conditioning, you've got that background.
Yeah.
And so I don't have any of that. So I look at the breath in a very different way to you.
Yeah.
And so I'd love to know, what do you think, what insights has that given you? In particular, I'm interested in strength and conditioning. What insights has that given you into the physiology of the human and the breathing?
Yeah, I think there's twofold on it, really, in that, like, part of me probably comes to breathing from a different perspective of a lot of people, because I knew nothing about breathing when I played professional rugby, and then I went into strength and conditioning, working with predominantly Paralympic athletes, and I remember I did my Oxygen Vantage certification. I'd been working with athletes up until the Rio 2016 games, and then still one or two until like the Tokyo games that got postponed. And I remember when I did the training for the Oxygen Vantage, it was actually just for me, for my own breathing. I was aware about the effect of breathing on brain health, and I'd retired from pro rugby because of a brain injury. So I'd actually was doing it, not selfishly, but just sort of doing it for myself. And weirdly, I don't know why, I didn't think at all that it was something I was going to use with the athletes I was training, because it just wasn't something that we did. Like, and I've got to the place now where I'm like, okay, how on earth, as an S&C coach, and a lot of the athletes with the Paralympic athletes we're working with, a lot of them were either runners or swimmers. And it's like, breathing's massively important in those things. But it just wasn't on the radar. And one of the things that I am very passionate about is going, like, why isn't this on the radar? Like, let's not think about breathing as something that we can't train, something that isn't a movement pattern like something else is a movement pattern in the body. Like, what is it comprised of? How does the functional anatomy work? What's contracting? What's moving? What muscles are involved? And then going, okay, what's the optimal type of movement that we're looking for? What's some of the ways that we can train it? And I sort of look at breathing from that S&C sort of lens, which I think I can't not look at it like that, because that's just how the background I've had in training. And so these two things come together where I'm like, I can't believe we didn't get taught and look at breathing as an S&C coach. And then I'm also at the same time coming at it as an S&C coach and going, like, okay, how do I assess someone's breathing in terms of their movement? How is it affecting the rest of the kinetic chain? How is it affecting how they put down force? How is it affecting their aerobic and anaerobic systems? Is there things that we can do that is going to allow us to optimize those systems? And the more I look at breathing, the more it can influence all aspects of our sort of physical and mental performance and recovery, which is amazing. But then at the same time, as a coach, is then quite challenging, because then the more you do everything, the more diluted it can potentially come. So it's like, it's like we can do all these things. And then I think something I'm trying to do now is go, like, okay, with all those things, how do we distill it down to the most important things for that particular sport or individual?
So I've just come back from JITS training session.
Yeah,
I've got a bit of I don't know, chesty cough thing going on. My breathing was really hard today. I felt real sympathy for some of my clients today, because I was like, could not get my breath back, and I was like, wow, I was fine a week ago. What, in your opinion, working with athletes, is a good recovery breath in between rounds of, like, on the football pitch, rugby? Because, you know, I'm trying to do I call it piggy nose. I'm lifting up the nose, I'm spreading this, and I'm trying to stay nasal. But then I've know other people that will, and they'll blow off a load of CO2 so they can go back again. So what have you seen that works best in active recovery between?
Yeah, exactly. I mean, I've done a whole podcast episode just on live recovery. Like, this could be quite big, but I'll try and distill it down if I'm any good at what I'm doing, and I should be able to distill it down. The annoying answer is initially that it's important to just contextualize that it depends. If the training session purpose is, I want to, let me put it this way. I've got like three options almost. I've got, like, make my recovery easier in the moment. I've got, and then just understanding, like we'll go into understanding how breathing could be used for that. Whether I just sort of deal with the discomfort of trying to control my breathing and put things into place so that I, in the long term, will improve my recovery, but just in the moment, it's going to feel a bit harder. Or I can actually purposefully make breathing harder during my recovery so that it's absolutely disgusting in training, but that creates adaptation. The same way, like when you put weight on a bar and do squats, it doesn't make you better at squats right there and then. You're actually trying to create a stress, a physical like stress that you've got to overcome with a weight, a force. And once you've recovered and adapted, then you get better. So what that might look like in those three different scenarios, in order to get your breathing, or let me go, I can go, before I go there, I'll go like a bit of a theme, something that I will always try to get across in my sort of like first session, if you like, in terms of managing breathing with recovery. The volume of air that you're breathing is dictated by the size of each breath, tidal volume, and the speed of your breathing, your respiratory rate. Those two things create the volume of air that you're breathing. The speed of your breathing is like the key metric in terms of if that gets too fast and you can't control it, the volume of your breath goes out the window. Yeah, becomes short and shallow, and the mechanics go out of the window. So you start becoming very inefficient with your breathing when you lose control of the rate. So being able to control the rate of your breathing, really important. So when we're thinking about recovery, we actually want to start thinking about our breathing, not necessarily thinking about, but something as a coach I'm thinking about, how can I help them with their breathing during the exercise so they're already a bit more in control before we then go and now do the breathing recovery. Does that make sense? Mm-hmm. So being able to manage the rate of your breathing. Your CO2 tolerance goes into that. Your psychological relationship with feeling out of breath goes into that. Your mechanics goes into that. All things that we can train. Now, if we're going to make breathing, so before we get into that, the thing for recovery that's always going to be some coaching cues from me is get control of your exhalation and try to get back to nasal. And the back is an important word in that, because depending on the intensity of the exercise someone's doing and depending on where they're at in their ability to nasal breathe and the shape and structure of their airway, their nose and all these things, they might have to be mouth breathing at that point. So if I say get back to nasal, it gives them permission to use their mouth. But what's important for me is that just because you're using your mouth, you don't have terrible control of the rate of your breathing and terrible volume of breathing and terrible mechanics of breathing. Because one thing that I guess a little thing that frustrates me a little bit at the moment is people see a bit about breathing and they maybe see a tennis player with their mouth taped on the training court and it's like, all right, you've just got to breathe through your nose. And it's like, that's just one element of it. And depending on the circumstance, it might be incredibly stressful to breathe through your nose. So get control of your exhale is a really important one, and get back to nasal.
The following is a clip from Dr. Lim. Dr. Lim is a dentist/orthodontist, and she wrote a book called Breathe, Sleep, Thrive. And she has a very wonderful take on things such as tongue tie and respiratory health of young people and how that translates to issues with us as we grow older. I learned a lot from Dr. Lim, and I highly encourage you to enjoy the clip and then check out the full podcast. Okay, let's talk about tongue ties, something very close to my heart. My son was tongue-tied. We had him done it, I think, 6 or 8 weeks. I'm tongue-tied, but I haven't had mine done. Give me your thoughts on why does the tongue tie even present? Is there, because again, this is way too simplified, but people talk about the evolutionary benefits. Mother Nature doesn't waste anything. But so what would be even the point of there being a tongue tie? Or is it like a misfire in nature? So just give us your thoughts, if you can, first of all, on Why are there tongue ties? And are we seeing more tongue ties, or are they being more identified? So yeah, just give me an overall holistic view of tongue ties if you could first.
Yeah, well, tongue tie is thought to be a failure of apoptosis or programmed cell death. So normally the cells would resorb away before birth, but somehow that's not happening. And I'm really not 100% sure as to why that is the case. Is there an increased incidence? I'm not 100% sure either. Because a lot of the research that's done on tongue tie, they're only looking for anterior tongue tie, or the tongue tie that is restricting all the way to the tip of the tongue. But now we know that even those more hidden ones, or sometimes they're called posterior tongue tie, they impact the elevation of the mid-tongue, which is so important for sucking, swallowing, and breathing, and good palate development. And so there's a lot more awareness of that now. And so we're definitely starting to recognize that a lot more. And I'm seeing, older patients, adults, and it's been very underdiagnosed. So it could be that we're just a lot more aware of it now that we understand the implications and how it can affect so many other functions beyond breastfeeding.
And what are those other functions? So let's say we've gone past the breastfeeding phase and we've still got the tongue tie. What are those other challenges that present later?
Well, even in babies, if you have a tongue tie and then you get around it by going onto a bottle, whether you're on the breast or bottle, we need it for good swallowing. We need the good tongue elevation. And sometimes if we have a tongue tie, we can actually swallow a lot of air as a baby. So I see that a lot in babies where they're sucking a lot of air, they're making a lot of noise, clicking on the bottle, and that can be linked to reflux-like symptoms, or sometimes called aerophagia, where children may be really unsettled and difficult to put down, stiff and arching, pulling on and off the bottle, and throwing up, vomiting, very gassy. It can create a lot of misery for these babies and for parents as well, because sometimes babies are put on reflux medications and they're not particularly well proven or studied, and the symptoms don't go away. But sometimes we got to check if we're going to medicate a baby, or if they have reflux symptoms or colic symptoms, check that they're not swallowing air. Because if that tongue can't lift properly, we're not going to swallow well. And that's when we get more air introduced as well. So what else do we need? We need our tongue for swallowing solids as well, and manipulating our food. So maybe in the toddler age group, we might see children that are struggling more with their solids or choking or gagging. We also know that there is research to suggest that the tongue up is really important to stimulate palate receptors, and it's really important for speech perception as well. So there's a sensory motor component where we need the tongue up to perceive sounds. And so if the tongue is not up, that may be implicated in speech delay, whether it's a tongue tie or whether it's a pacifier. So that's really important, as well as speech. For speech articulation, we need good tongue elevation. Otherwise, we may have more lisp and mispronunciations. And so what I see is a lot of babies, or children, that have been in speech therapy for 3 years and they're really not getting ahead. So we need to make sure that the tongue can elevate correctly. And I actually see a lot of children that have tongue tie that can speak perfectly clearly. You can really understand them. But when I watch their mouth, because I take a lot of videos, you can actually see that they make their speech sounds with their lips and their cheeks, and they're using other muscles they shouldn't. Now, the problem with all these compensations, when we use muscles that we shouldn't, whether it be muscles of our neck or jaw or our face, is that we don't develop good tongue tone. And why do we need really good tongue tone? Because we need good tongue to palate suction during sleep. When all the muscles are really relaxed, we want that tongue functioning well during childhood to develop that palate. But also the tongue, the bulk of the tongue is formed by the genioglossus muscle, which is the main upper airway dilator muscle. It keeps the throat open. So it needs to work well, and it will play out during sleep eventually down the track if it's not working well, when all our muscles are more relaxed. When that tongue is not sitting up and it's more down, that base of the tongue, it becomes very flaccid. And it's the base of the tongue that is more prone to obstructing the throat during sleep. And so, there is a lot of evidence now, or quite a few papers now, to link tongue tie to the development of obstructive sleep apnea. But we have to remember obstructive sleep apnea is a very end-stage problem, and it may not present till much later on in life. And so one of the earlier clues that can happen is a lot of teeth grinding, or it's kind of like a protective mechanism. So when we're young, we have a fight or flight response, a sympathetic nervous response, so that's really intact. And so anytime there is a narrowing of our airway, we have an arousal from sleep, from deep to lighter sleep, and like grinding to recruit the jaw muscles and to keep the airway open. So there's a lot of issues that can be associated with a tongue tie. But a lot of the time they get dismissed or missed because we compensate. We can use other muscles, and we can give babies bottles or give them shields. We can do this speech therapy. We can do a lot of things, but we also introduce these compensations that don't allow the tongue to do its most important jobs during breathing and jaw development.
So let's talk about palates a little bit then. So I've noticed that my tongue doesn't really fit in my teeth. I have to like kind of bend it in. So if my tongue was to stretch, it's way above the teeth. So can you talk about palate extensions, adults and children, and like, so let's just say I had my upper palate opened up. Would you then have to have your bottom palate opened up as well? So if you could just share a bit about what that all looks like, because I don't really know too much about that, and that seems very interesting.
Yeah. Palate expansion is really about using an orthodontic appliance inside the mouth. There's a screw mechanism, and the idea, it sort of sits in the mid-palate, and the idea with that is when you turn the screw, it introduces a force that can actually help to lightly separate the two halves of the palate, and that stimulates new bone to form in the mid-palate. So the mid-palate being the floor of the nose, when we widen that, that can actually help with nasal breathing improvements, as well as making more tongue space. So it's really effective in children. The reason why it works so well in children is because there's a mid-palate suture and it's not completely fused. It doesn't really start fusing till age 9, and any force will actually separate that, and we can get predictable bony expansion. But then as we hit teen years and adulthood, that suture becomes really fused, and we've got to do other techniques to be able to achieve that. And so if we use traditional expanders in the non-growing people, it would tip the teeth, like the force would move the teeth rather than actually stimulating this bone expansion in the midline. And so to overcome that, and there's a lot more people doing it, there's mini implants or TAD supported expansion, where there's tiny little screws that are drilled into the bone next to the mid palate. So in the height of the palate, next to the mid palate suture, and then an expander or screw mechanism can be attached to those mini screws. And so when you turn the key, instead of the teeth supporting the expander, the bone supports the expander, and that force is placed more directly across the palate. So the suture can open better, and you can get more results that are similar to what you can do in childhood. So that is palate expansion. What was the next question again?
With adults, do you have to do the bottom palate as well?
Oh, yes.
Then?
Yeah, it's actually not possible to expand the bone on the bottom. But usually what happens is when you have a constricted palate, usually the bottom teeth are tilted in like this. If there's no crossbite, like sometimes there'll be a crossbite where the jaws don't match together as well, but sometimes it'll look like the top teeth are sitting on the outside of the bottom teeth, and that's only because the bottom teeth are compensating. They're leaning inwards like that. So usually when you do it, so for instance, if I do it on a child, quite often I'll just do the upper expansion and work on the jaw muscles so we're not getting inward contraction of the cheeks, and that can allow the permanent teeth to erupt more straight. But if you're an adult, you would then use braces to upright those upper teeth. So to get everything to fix. You can't really grow the bone in the top jaw.
Okay, that's interesting. Because that top, because there's like a thing in the brain at the skull, isn't there? There's like 3 parts, and they fuse together. And I've seen that there's something similar in the upper palate is there, but so about age 9 that seals. So I've seen like Dr. Belfour talk about, I think it's the homeo block, and he's doing some stuff with adults as well. But that's not really changing the palate then, is it? Palate's fused. Or is it, does it crack it open?
Yeah, generally speaking, if we use the plastic appliances, they are not as reliable to get those bony changes, and they're not as quick, and they're not as well published either. So yes, people may have success, but for instance, if we have a very narrow palate and a problem with breathing and sleep, and we want to get a quick improvement, we're going to go with the more well-documented approaches that are very well studied, and they have the evidence to support it.
So breathing into sleep, I'd love to get your thoughts on this. How is the breath affecting the quality of sleep?
Yeah, well, I think that if you try to snore with your mouth open, it's a lot easier than with your mouth closed. So when we close our mouth and we have our tongue sitting high inside the mouth, we're going to have a more stable airway. And whereas when we open our mouth and our jaw drops and swings back, we're going to have a more pinched airway, and it's going to be less stable. And, you know, it's not going to be as smooth an airflow. So that's when we're going to have more interruptions of our breathing and collapses of the airway.
Mm-hmm. And so with adults as well, when we get that snoring, because there's a couple of types of snoring, right? There's that, but there's also like, you can snore with your mouth closed, can't you? And you get that like horrible back of the what does that do to sleep quality then, if you've got a mouth breath, or just because I've heard things like you're going to struggle to get into the deeper levels of sleep, like you might not get as much REM, or you might not get as much deep sleep. Is there any truth to that with disruptions of sleep? And if so, maybe expand on that a little bit more. Why would that affect those particular levels?
Well, when we have our mouth closed and we have that more smooth laminar airflow, it's less interrupted. However, if we have a more turbulent airflow and it's harder to get the air flowing, it's going to be more disruptive. And so we're going to get in and out of that deep to light sleep. And that sleep fragmentation, it's actually going to affect the quality of our sleep. It's not going to be as restorative. So we know, for instance, there's some research to suggest that even children that mouth breathe, not necessarily snore, they have an increased risk, or there's an increased prevalence in ADHD type symptoms with their attention and concentration. And that's really related to the fragmentation of their sleep because of that interruption from their breathing.
So could that then, if you link that back, would you say that, well, actually the ADHD is actually just tiredness, or is there also another level where the brain's not getting its restoration, and so the brain's not operating? So is there something more than just the tiredness that's presenting as ADHD, or is there something else happening neurologically, do you think?
Yeah, there's a lot of research to link snoring to increased difficulties with behavior and learning. And there's a couple of different mechanisms. Like you said, it is related to the fragmentation of sleep and a child being more overtired. So if a child is not getting good sleep, they're not going to present like an adult where we get more sleepy and more lethargic. A child may present with symptoms of overtiredness or difficulties with their emotional regulation, or difficulties sitting still. So that can be ADHD-like symptoms. And at the same time, we know that there's a lot of research to support that when children snore, there's actually alterations in their grey matter. So there's reductions in their volume. So we don't really know exactly the impact or how that's going to play out for each individual child. But yeah, there is that definite link that is occurring for children.
Okay. And if we, I know every case is different, but if we've got a child that is mouth breathing and we're noticing its mouth's open at night, I heard something about in the Victorian times they would gently place the lips closed. What could or should parents do if they've noticed their child is a mouth breather?
Yeah, from infancy, if we notice that a child has their mouth open, we should try to close their mouth. And we want to see that tongue sealing to the roof of the mouth. because when the tongue is lightly suctioned to the roof of the mouth where it belongs, it's actually impossible to mouth breathe. And it's easier just to close your lips. So that's something simple that can work for some babies, and maybe not for all, but that could just be a red flag that we may need to watch more closely as they get older and to see what other options are available. So just making sure that children, they have clear nasal airways. If there's any congestion, we're actually using nasal sprays, and if they're little, to aspirate that out of their nose as well. And as children get older, what we want to do is just, it could be like a toddler or an older child putting a paddle pop stick between their lips and getting them to have that while they're doing other activities. But I also think it's really important not to overlook the structural contribution of the palate, because when the palate is narrow, and that is the floor of the nose, we're going to have a narrower nasal passage and reduced cross-section of the nasal airway. So that's going to increase resistance to nasal airflow, and we actually, it makes that more easy to open your mouth as well. And different things like allergies, we want to really minimize the incidence by doing the preventive measures, making sure we have dust-free homes, not letting children sleep with their pets. Around the age of 2 to 3, we're just looking at enlarged adenoids and tonsils, because they can be they can peak in size around their age group as well. So there's a lot of things that we need to look for. And I think probably one of the most overlooked is the contribution of the palate.
Hey, thank you so much for sticking to the end of the podcast. What's one thing that you're going to remember to do off the back of this podcast? Make a note of it, put it in the comments, share it as a tweet or an X, whatever they're called these days, because what I'm trying to do for myself is not make podcasts into Netflix where I binge them and can't remember anything. The gold, the treasure is in taking action. So what's one action that you can take off the back of this podcast? And before we jump into the breathing exercise this week, as you know, on this podcast, we like to close off with breathing. I would like to talk to you about Breathwork in a Blink. It's my completely free email newsletter. We have over 10,000 people subscribed to this newsletter now, which is unbelievable. And every Friday, I share with you my top tricks and hacks and gadgets and gizmos and breathing techniques and studies. And it's all been designed that you can just scan through it in under 5 minutes. So you can find the thing that's interesting to you, click on the link if you want to, and it's just packed full of goodies. I do that once a week. I write it myself. It's where my mind has been that week as well. And I really asked myself, what email would I want to get if it was coming into my inbox? So I've really thought about that to provide you with as much value as possible. So I hope you enjoy. The link is down below. Breathwork in a Blink in under 5 minutes. Hello, Breathwork goodies for you. Okay, let's get ready for the breathing exercise to close this podcast. So just feel free to close your eyes. Just start to notice your breath. Just start to soften it slightly. And we'll begin the breathing exercise in a few seconds. Thank you so much for being with us on Take a Deep Breath. Welcome to Take a Deep Breath. Over the next 5 minutes, I will guide you through a very simple breathing meditation that will help you relax, unwind, and feel less stress. Let's start by sitting or lying down, and if you like, you can close your eyes. You can simply listen to my voice as I guide you into a deeper state of relaxation. If thoughts come into your mind, that's okay. Allow them to come and go, because all the time we will bring our attention back to our breath. For now, just observe your breath. How is the breath at this moment? Is it shallow? Is it fast? Is it slow? Is it deep? Just bring attention to your breath and bring attention to your body. If you like, you can place one hand on your tummy. This will help you feel your breath. Pay attention to the slightly cooler air as it comes into your nose, and the slightly warmer air that leaves your nose. The rhythm of in and out. Inhale and exhale. Okay, I'd like you now to begin to slow your breathing down ever so slightly. Make that inhale a little longer and make the exhale also a little longer. If you can, make that inhale a little bit deeper and extend that exhale a little longer. As you breathe in, maybe add just a little pause before the exhale, and as you breathe out, again add just that slightest of pause before we go back for the next inhale of breath. To know that breath is life and life is breath, and this wonderful gift we have of conscious breathing. In through the nose and out through the nose. Not worrying if our attention is taken elsewhere, because at any point we can feel the air coming in through our nose and out through our nose, and we can bring our attention always back to the anchor, which is our breath. Many people don't realise we carry a lot of tension in our head. So now, relax your forehead, relax your jaw, unclench it if it's clenched or tight, and relax the little muscles that sit behind your eyes. As we move down through the body, relax your shoulders and scan down the body. And as we slowly scan all the way down to our toes, just sensing anything that might be tight or sore and relaxing where we can. And remember, if at any moment we start to drift, then back to the breath. In deeply through the nose and out through the nose. Slow conscious breathing like this has been proven to help us unwind, to help us relax, and to help us change our state. And we know, don't we, deep inside, by spending a few moments on ourselves with a practice such as this, we can feel the difference. We feel calmer and more relaxed. Know that this exercise is always with you, no matter what the situation, no matter where you are. You can always breathe in slowly and deeply through your nose and slowly and deeply out your nose. In a moment, I'm going to ask you to open your eyes, but before I do, let me congratulate you and say thank you for taking some time